So the topic, I have no conflict of interest. I had some research funding from Astute Medical, and I collaborated with Philips North America Research without any funding. So I'm trying to kind of go over evolution of biomarkers and sniffers or acute kidney injury e-alerts and try to, at the end, marry these two together to see how we can actually eventually start using these two technologies to enhance the care that we provide to our patients with acute kidney injury. So first about acute kidney injury biomarkers. As you know, the current state is really interesting because a few years ago we didn't have any of these modern biomarkers about 15 years ago or so. Current state is, in the clinical practice, however, is very limited. Is for differential diagnosis, for early detection and prognosis, we only have limited artillery in our toolbox, and we potentially cannot use widespreadly use biomarkers as we potentially can. So the list is long for each utility of biomarkers, including differential diagnosis. I added this gray box because these two biomarkers came after the publication of this particular review paper. So generally, we try to rely on traditional ways of diagnosis and differential diagnosis of acute kidney injury. Unfortunately, symptoms and signs in kidney injury is very nonspecific. We can have patients with a lot of urine or no urine. We can have different levels of change of mental status, different levels of electrolyte abnormalities. We can have patients who are hypovolemic hypotensive or hypervolemic hypertensive and have acute kidney injury. So it is very difficult to identify a particular reason for acute kidney injury just relying on physical examination and history. However, it is important to have all this information in toolbox. Then we use urine indices to identify what used to be called prerenal versus tubular damage or acute tubular injury. And particularly in sepsis, the information and the data that supports this particular utilization of indexes is very poor. Indeed, this is only used as a confirmatory test for a lot of pathophysiological development in acute kidney injury. What is very useful, however, is urine sediments. Urine sediments are not sensitive. A lot of patients with acute kidney injury have bland urine. However, if you can find sediments, then it would be very specific. You can rely on that to identify the cause of acute kidney injury per se. Then we have echo and ultrasonography. Ultrasound has been used and with a growing frequency among nephrologists and intensivists to identify different pathologies in acute kidney injury. And holy grail of acute kidney injury diagnosis, biopsy, that we never do. So biopsy for acute kidney injury is very rarely done. However, that could be potentially one of the next few years adventures to try to biopsy these patients with acute kidney injury in ICU and hospital to try to understand pathophysiology and the disease itself. Now, for that reason, we are going to need a little more sensitive biomarkers. As I showed you, a lot of current biomarkers, including serum creatinine urine output, have a lot of limitation on identifying patients at the very beginning of declining kidney function. And as you know, when kidney function continues to decline, mortality increases, and traditional biomarkers identify this patient really late in the course, which doesn't allow us to provide significantly effective preventive measures. So looking into biomarkers, this is a very well done systematic analysis of biomarkers, and the authors conclude that promising results with new biomarkers for early detection and differential diagnosis of acute kidney injury in clinical practice can only be confirmed in the setting of children without comorbidities and with a well-defined timing of renal injury. This is because most of the initial studies were done in cardiopulmonary bypass surgery among pediatric patient population. As you know, know, these patient population have only one single organ failure, and they go through surgery, which is a timed injury. They do not usually get contrast for angiography before surgery. So it is very defined, well-defined time of injury. However, the authors go ahead and say that results are far less robust when we search for validation in adult heterogenic population, including patients with comorbid conditions like diabetes, vascular disease, and chronic kidney disease. And as a result, the initial excitement of a lot of biomarkers that were validated in pediatric population subsided when we moved to adult patient population. The other factor we need to consider is that functional markers and injury markers are complementary. They are not in different direction. We have to use both of them to be able to identify patients that need more attention. So in this 2x2 table that was suggested by AKI 10, you can see functional biomarkers negative and positive, and injury biomarkers negative and positive. Obviously, those who have negative injury and functional biomarkers have no acute kidney injury. Those with injury biomarkers but no increase in creatinine or no decline in urine output have subclinical acute kidney injury. I'll show you some data from Tribaki cohort that shows that this actually is important. What we used to call prerenal are those who have elevated serum creatinine, but there is no evidence of injury among them. This is what the prerenal definition intended to. And then obviously those who have increased injury and functional biomarkers have true acute kidney injury. These are two examples, IL-18 and NGAL. In one single study, they looked into post-surgical patients, and they defined acute kidney injury more than 100% increase in serum creatinine or the need for dialysis. They noticed that obviously urinary IL-18 day 1 after surgery increases while acute kidney injury is not developed yet. And then this would be every hour that passes, the amount of this IL-18 increases over time, and this remains elevated through the course to day 2 and day 3. And indeed, there is a dose-response relationship in this cohort as well. Indeed, those who have cutoff of IL-18 more than 60 picogram per ml, they have about 7 times higher chance of development of acute kidney injury. Same study looked into plasma NGAL, found the same thing. So earlier elevation of urine NGAL, although you see there's a good overlap between those who didn't develop acute kidney injury, and that speaks of non-specificity of NGAL. And then again, those who reached the cutoff of last quantile of more than 293 nanogram per ml, they have about 5 times chance of acute kidney injury. And they resulted they did the ROC analysis, and they found that IL-18 or plasma NGAL and urine NGAL all have area under curve of about 0.7, which makes them a very fair test into the prediction of acute kidney injury post-surgical. Now, this is a very interesting study. They looked into different biomarkers, compared those mortality, those who did not have acute kidney injury and acute kidney injury. As you can see, mortality, these are patients who did not have acute kidney injury based on serum creatinine. And as you can see, this mortality of these patients when they have higher level of NGAL is the same as mortality as those who had acute kidney injury but had the lowest amount of increase in biomarkers, which means potentially that those who have subclinical and prerenal, they probably have the same outcome. The same stands true for urinary IL-18, KIM1, not much for LFAB, and also for urine albumin-creatinine ratio. Now, that resulted the need for newer biomarkers that we started working on the discovery cohort of 500. We measured about 340 proteins that we thought that could be related to patients in timely manner. We identified 2 biomarkers, proteins that could potentially be meaningful. And this was eventually under leadership of Professor Kellum, was validated in a large cohort of 728 patients for detection of acute kidney injury stage 2 and 3, 12 hours ahead of time. And as you can see, performance of these biomarkers in comparison with usual biomarkers known in the market at the time, it appears to be superior. And again, measuring one of these measurements at the time of enrollment was able to predict mortality in 9-month follow-up. And as you can see, curves continue to diverge for 9-month follow-up even in this study. Further, we kind of thought that we have to find inflection points to come up with cutoffs. And then in OPAL study, Dr. Host and his group, they looked into Sapphire cohort along with another 150 patients and came up with two cutoffs. One is sensitivity threshold, that this cutoff has high sensitivity but is not very specific. So you can use it for screening patients for acute kidney injury risk, and a specificity threshold of more than 2, which means that these patients have very low sensitivity but very high specificity. Whoever has NephroCheck more than 2 has very high chance of development of acute kidney injury. This further was validated by Dr. Biorak and colleagues in a different cohort in North America, 408 patients, and they found exactly the same thing. Performance is about the same, area under curve of 0.82. And they said that, well, biomarkers should add something to the clinical judgment. So they come up with a clinical model for prediction of acute kidney injury. In the first column, performance was 0.7 area under curve. However, when they added biomarker to the same model, they had significant improvement in the performance of the model. That means that potentially these biomarkers are able to add value to the clinical judgment. They are not to replace clinical judgment. They work with the clinical judgment to increase the value. Now, there are a couple of newer biomarkers I thought that we should probably talk about. Chitinase 3-like protein, which has a very kind of undifferentiated physiological pattern. However, in a study done by Dr. Host group in Belgium, they found there is a dose-response relationship between chitinase 3 level and the stages of acute kidney injury. So this is kind of something to stay tuned for further information. The other biomarker, which is a functional biomarker, is a proenkephalin. There's a protein excreted in the kidney, and there is a strong association between proenkephalin and kidney function in sepsis. As you can see, that when proenkephalin increases GFR, measured by creatinine clearance shows a decline. And interestingly, out of the factors among these patients, what actually impacts proenkephalin level is GFR. It is not having sepsis or being sick or age or gender. So this is making proenkephalin slightly more specific towards acute kidney injury and GFR. And in comparison with serum creatinine that increases in about 40 hours after development of acute kidney injury, proenkephalin shows more rapid increase in level in plasma, therefore could be potentially used as early biomarkers of a biomarker of acute kidney injury. So this was meant to be a joke in ASN 2006 that they compared nephrologists with cardiologists. They said cardiologists keep adding to the artillery of their tools and they have better outcomes. We stuck with serum creatinine for many, many years. As of that time, we have been able to add a lot of biomarkers. I'm glad that joke was made that started us thinking about coming up with the newer biomarkers. Now, switching gears to AKI e-alert and its evolution. So we know that the first computers in ICU was not placed in ICU that long ago. In 1953, first cerebral artery pressure meter, and then EKG machines came to life. In 1960, was first hospital information system implemented. In 61, when first person in space was done, first computer in ICU was used in USC, and first ICU monitor was used in Japan in 1967. So the age of this guy is the same age as mine. So we both are 50-year-old and happy 50-year-old. Now, following that, there are further development of the capacity of this. As you heard from Professor Fijin yesterday in opening ceremony as a keynote speaker, there are significant improvement exponentially adds to the capacity of these tools. And since 1973 up to now, we have moved from first generation to the third generation, but there is significant room to improve as well. So this is a machine in Japan that is the size of a bed, so they couldn't put it actually in patient's room. They had to put it in a different place and dedicated nurse to monitor this particular tool. As you see, this tower of monitors for a patient is larger than patient, and yet this is not enough, so they had to add another person in a different room to be able to see the results from this and try to interpret it. Now, all of this has become significantly smaller and more effective. You all remember this type of medical records. They were handwritten, and this person who made this note has a good handwriting, it's legible. Most of the notes were illegible. When I started my internship, I couldn't read my faculty notes, so I had to kind of travel with them and ask them to read it for me. Then we moved to this particular type of medical record viewers that they were adopted from accounting databases. So the same way that accountants put numbers for money, we use that for medical record presentation. Recently, we came up with this new ambient system. We call it AWARE, that presents all the data based on each organ system and presents data that we actually get to use. So for the last one, we told the technicians, IT folks, that we understand that you have the technology and understanding to generate this type of medical record systems, but we really need something that we can use better. Therefore, we collaborated with them and we came up with this system that is currently even commercially available. So how this system can help us to manage acute kidney injury? So first of all, a lot of studies recently have been focused on AKI alerts. So alerts that can identify patients with acute kidney injury in ICUs. So for that matter, we need to have access to a lot of databases. As you mentioned, third generation of medical records are excellent in visualization, excellent in representation. However, they're very fragmented. So there are many databases that are not linked together. So we need to link them together in repositorium of data and try to analyze it in the right way to generate some more knowledge that is based on analysis of data gathered in this linked system. And that has to be able to generate some information that can go to providers as an email or pager or overhead page or some sort of report by the administrators. So this is the sniffer that we developed, and it is currently in my office. We use it for research purposes, and we are hoping that we can redesign our practice based on this sniffer. So each folder is a patient. Each patient is assigned 4 numbers, 0 to 3. 0 is no AKI, and 1 to 3 is AKI. If I push over the 3, it shows me what time is the progress of acute kidney injury has been. So 4 hours after admission, patient reached the criteria stage 2, and then about 12 hours later reached the stage 3. When I want to see what criterion resulted acute kidney injury, also shows us serum creatinine and urine output as an average, and gives us some based on information of how based on creatinine was calculated or measured, and also what is the average urine output. We wanted to go a little beyond that because detection of acute kidney injury, although extremely important, is often missed. Prediction is even more important because when acute kidney injury develops, when patients reach criteria for acute kidney injury, it's often late to provide significant number of preventive measures. So we thought that we have to identify patients with a higher risk of acute kidney injury. Therefore, we try to come up with the prediction models that are not requiring clinicians to calculate that at the bedside. It should be kind of provided to them automatically. Because of computer-based of this prediction model, we were able to include large number of variables, including minute-by-minute changes of vital signs, blood pressure, urine output data that comes, and each intervention or each exposure, if you order gentamicin on a patient who is very hypotensive, it changes prediction of acute kidney injury. So this information goes to the model, and model generates a score of 0 to 100, and this portrays one patient's data. So this patient came into ICU with a score of 75. Score continued to increase after receiving 3-4 liters of normal saline and given vancomycin, and blood pressure continued to decline. About 12 hours later, sniffer that I showed you earlier went off, showed patient actually developed acute kidney injury. Over time, with improvement of the risk, patient started making urine, treated for sepsis, and recovered. Now, detection and prediction are not the only two things that we can expect from a clinical decision support system for acute kidney. There are a lot of other activities that they can do. They can remind us that we should order vancomycin level. They can critique us for what we do, reject us if order that we place for patient is not correct. For example, dosing is not correct. They can help us to interpret data. They can gather all this information and say we think that proximal tubule is currently injured because of these factors. They can help us predict. They can help us diagnose. They can assist us and suggest antibiotic dosing, and they can suggest to generate adjusting dialysis dose for patients who have progressive acute kidney injury. Now, to be able to reach that, we need to have 3 separate components. Obviously, patient's specific information is extremely important. All this data goes to clinical decision support. But knowledge base is also important. So if my clinical decision support gathers all information, does really well in prediction, but is based on the knowledge of critical care management in 2003, when we were flooding patients with a lot of fluid and normal saline, that may actually cause harm. So we have to update that very frequently. So then the third component is what links these two together to generate information and recommendation to clinicians. So the purpose of these clinical decision support systems are to provide right information to right person in a right format, so people don't ignore it all the time, from a right channel and on right time. So if alert comes to you about 24 hours after acute kidney injury risk is elevated, then it's not going to be that useful. So indeed, what we really want eventually is something like GPS. You know, GPS is always wrong if the knowledge of GPS is not updated. If the GPS doesn't get updated on the road construction, then it takes you to the wrong direction. Therefore, knowledge base is extremely important to be constantly updated. It has to have excellent integration of the data and knowledge. It has to have significant visualization. And we need to kind of define what we want this for us to do based on proven knowledge and data algorithms. Now, how we can marry these two together? Clinical approach based on identification of patients' risk for acute kidney injury is extremely important. This is adapted from Professor Kellum's presentation that he divides patients based on clinical evidence of AKI, so those who don't have AKI, clinical suspicion, and in this case, an example is urinary TIM2 and IGF-BP7. So what he comes up with, if patient doesn't have evidence of AKI and has low clinical risk and biomarker is low, then patient is low risk, and comes up with a list of things that we should probably do. But the moderate risk are those who don't have acute kidney injury yet, clinically low risk, but biomarkers show elevated risk. And then high-risk patients are those who have acute kidney injury already. Any acute kidney injury with high clinical suspicion, it doesn't really matter biomarkers. And those who don't have acute kidney injury, they have low risk, but biomarkers extremely high. They are considered very high risk. So in a pictorial presentation of the same thing, if we can identify patients that are higher risk based on biomarkers, we can actually start working on high-risk recommendation from KDIGO guideline or recently published European guidelines of prevention of acute kidney injury. So things that we can potentially do is monitoring serum creatinine, different frequencies, monitor urine output, ensure volume, status hemodynamic management. Professor Zarbach recently published prevention of acute kidney injury in cardiovascular surgery, showed hemodynamic management actually prevents acute kidney injury. Avoid nephrotoxins, cardiac management, and also recheck markers based on different levels of risk. So this is what we do right now. We have patients who present to emergency department with the baggage of comorbidities and critical illness. They go to ICU and emergency department. They get exposed to a lot of antibiotics, large amount of fluid, pressors, and so forth. And then develop acute kidney injury. Intensivists do a lot of work to kind of try to manage that. They give them Lasix, and as Professor Bellomo mentioned earlier, and they also try to fluid overload them sometimes, and patients go from stage 1 to 3. Obviously, at the end, they call nephrologists, and whenever they call us to go to ICU, we generally end up saying that, well, this patient is very close to dialysis, let's start dialysis. This is too late for us to get engaged. Now, how can we change this paradigm? So we thought that biomarkers potentially can help, evolution of biomarkers can help. So we have patients that are clinically low risk or very high risk. They do not need biomarkers. Biomarkers are needed for those who are in equipoise. We don't know how much is the risk of those patients. And then using different levels of biomarkers, we can provide different practices. Now, Professor Ranko is going to describe this later on. We came up with this NephroCheck Rapid Response Team. It's a protocol that he has implemented in Vicenza and has significant data that he's going to share with us at the end of this session. Now, what we are going to suggest is that this paradigm, patient goes to emergency department or ICU admission. Acute risk injury is assessed by electronic health records. So if electronic health records or sniffers, they show that patient has high risk of acute kidney injury, then we go through this NephroCheck response team, measure biomarker, and perform all these steps, and then engage nephrologists early to not only provide dialysis as needed, but also participate in risk reduction and prevention as well. Take-home points: AKI is deadly complication of acute kidney injury. Acute illnesses, AKI is preventable. AKI care is currently suboptimal, mainly due to delay in diagnosis. Using acute kidney injury specific computer decision systems and biomarkers can potentially improve care provided to these patients with AKI. With that, I thank you for your attention.